Good afternoon, everyone. So I'll be speaking on pearls and pitfalls in the treatment of distal radius fractures. As we know, distal radius fractures are very common fractures, and usually we should not be able to fail if we remember the pearls. So the first point is we must know the normal anatomy of the distal radius. For example, there is a palmar tilt, which is average 11 degrees, and there is a radial tilt, average 23 degrees, and there is a radial length approximately 10 millimeters. Radius is longer as compared to ulna. And there is a ulnar variance, which may be plus minus 2 millimeters. This is normal. And then the other terms we use is radial shift. We see in comparison with the opposite side, and articular congruity, that is the step if there is an intra-articular fracture. So if there is a dorsal tilt, we know that normally there is a 12 degrees or 11 degrees of palmar tilt. If there is a dorsal tilt more than 10 degrees, radial tilt less than 10 degrees, radial shift more than 2 millimeters, or radial shortening more than 6 millimeters, if there is a plus variant more than 3 millimeters, or articular step of more than 2 millimeters, this is not acceptable. So is anatomical restoration of distal radius, as we talked in the last slide, is it necessary for all the fractures? I would say yes and no, because in high demand, young complex fractures with shortening and collapse, we should try to restore anatomy. While in elderly low demand individuals with osteoporotic bone and minimally displaced fractures, we may try non-operative. For example, this lady, she is an elderly lady. This is a minimally displaced fracture. You can see that there is some malunion. There's a prominence of the ulnar head, but still she has a good function. So you can treat such fractures non-operatively. Similarly, we should not miss the associated injuries. So this is another pearl. If you miss a distal radial ulnar joint dislocation or a scapholunate or lunotriquetral injury, then your results are not going to be good, even though you have restored the radius anatomy. So you have to look for these injuries, diagnose these injuries, and treat them at the same time. Another thing you must look for in all distal radius fracture is always look for the median nerve function. So this lady who had this fracture of distal radius around 2 months back, she was treated non-operatively, but her median nerve injury was, missed, and she came to us after 2 months of non-operative treatment. Look at the thinner eminence wasting, and this is the fracture which was treated non-operatively. It's not acceptable position. So we operated after 2 months of neglect, and we also released the median nerve by doing a carpal tunnel release. So that's the function. So you can see the scar, which includes the release of the carpal tunnel as well. Another 39 years old mountaineering injury. If you look at this X-ray, it looks, very, very innocent injury. But when you look at the CT scan, it's kind of a burst fracture. Look at the lateral, or you can say the sagittal section, and then it was treated with external fixator and K-wires. This is 2 years follow-up. Another 23 years old army captain, 2 months post-injury, was treated only on the basis of this innocently looking PA view. Lateral view was not done, but and this was the function at presentation after 2 months of non-operative treatment. when we did the palmar view, this lateral view, it was a volar Wharton fracture, which was subluxated. So it was treated by surgery, and that's the function. The other thing we should learn as a pearl is we should choose the implants judiciously. Don't jump to the more expensive and sophisticated plates in all the cases. So for that fracture, close reduction and K-wire fixation after removal of the K-wires, and that's the function. Now plate, if you have to do, you may go dorsal plating, you may do volar plating, but we must remember that the flexor tendons, they intimate dorsally and only at the watershed volarly. So dorsally, as you can see, they are intimate with all of the bone. These are the extensor tendon, while the flexor tendons, they are intimate only at the watershed line. So this is an example of a 22 years old dance teacher and A3 fracture who was treated by open reduction and simple plate, and that's the function. She went back to her profession. Another case, which is a C3 fracture, 32 years old male, it requires more number of plates. So one should be judicious in using the implants. You can use K-wire, you can use simple buttress plate, or you can use the special periarticular plates. So be judicious. The other thing is, as I mentioned, the distal radioulnar joint must be looked up in every distal radius fracture. This is a study from our institution, published long time back. So we must look for these fractures. So if you are doing plating, you must avoid the pitfalls, because the distal radius is not a rectangular bone, rather it is a wedge-shaped bone. So the screw tips, if they are out prominently on the dorsal side, in the lateral view, you may not be able to really see them well. So one should be very, very careful. And the other point is the screws of the plate, they should be in the subchondral bone, because this is the stronger part of the bone. So poor contact of locking screw with the subchondral bone, they are the cause of the failure of the implant. So this is a good contact. This is a good contact, but here the plate is too proximal. So this is a good contact. More than 4 millimeter proximal screw to the subchondral bone, insufficient strength of the construct. If the screws are too short, again they will lead to poor support. So locking screws at least 75% of the anterior-posterior diameter of the subchondral surface should be included. So distally angled screws, they neutralize the dorsal forces. So in a volar buttress plate, we need to neutralize the dorsal forces as well. So this is the watershed line. It is very important. Your plate should not be going distal to this line, otherwise it will irritate the tendons. If the plate is too ulnar, so that will restrict the supination. So placement of the plate is important. And if it is too radial, it will be prominent and it will cause pain. And also it may be a cause of the rupture of the flexor processus longus, as you can see in this case. So one can palpate the plate from the skin to see if the plate is too radial. So too prominent plate irritate the extensors. If there are prominent screw tips, as I mentioned, the distal radius is a wedge-shaped bone. So we should be very careful in, with the depth gauge, especially the locking plates. You should be short of the dorsal cortex. So this is the wedge shape, the screw going outside so they can rupture the tendons. So it is difficult to determine in the X-rays. We should always use 1 millimeter smaller screw. So unlearn the concept of bicortical purchase. Rely on the subchondral support, as I mentioned in the earlier slide. So no fluoroscopic view can guarantee that the tips are not irritating the tendons, especially when they are in the groove of the EPL. So what you can do is you can take special views, place the wrist on full roll of cast padding and elbow on the table like this to get the lateral view. So that will show you the exact position of the screws. Similarly, for the PA view, you can lift the wrist and the forearm again around 15 to 20 degrees. The other important pearl is prior to drilling, place a K-wire through the drill guide locked into the screw hole in the plate. Then remove the guide and plate, leaving the K-wire in place. Obtain a fluoroscopic view of the K-wire end on. You will actually come to know whether the K-wire is going into the joint or not. You can use arthroscope to know whether the implants are going through the joint, as in this case. Also, arthroscopy assisted is useful to see the free chondral fragments. Imperfect reduction plus prominent plate. The reduction will also be imperfect, and then there may be tendon ruptures. So in our country especially, there is a problem with of the coax leading to malunited fractures, like in this case. So you can do angular osteotomy of the radius and ulnar shortening. So in summary, we must know the normal anatomy of the distal radius. We should know the personality of the fracture by doing a proper X-ray views, and if needed, get the CT scan as well. We should choose the appropriate treatment depending upon the personality of the fracture, and the implants should be used very, very judiciously. If K-wire is required, only use K-wire fixation. If one plate is required, do one plate. More than one plate is required, do more than one plate. Optimum placement of the plate is important so that it does not become prominent and irritate the tendons, especially when it goes distal to the watershed line. The length of the screws should be optimum so that they do not lead to rupture of the tendons, especially on the dorsal side. So thank you very much.